So my name is Roger, and I'll be presenting a systematic review looking at blood transfusion strategies for patients with heart attacks, myocardial infarction. So I actually come from McMaster University. I'm finishing my Bachelor's of Health Sciences there. Everyone on the team was actually affiliated with McMaster to some degree, and our supervisor is Dr. Mark Crowther. There's a picture of him. Okay, so in terms of background on why we did this paper, we're looking at this condition, myocardial infarction, heart attacks, where the blood flow to the muscle of your own heart is restricted. And so the treatment goal in those situations is to restore that blood flow, and that can take different forms, but some of those, for instance, a bypass surgery, carries that risk of some severe bleeding, and a logical response to that would be to give a red blood cell transfusion. And we talked a lot about, I think, earlier today, how there are some risks with blood transfusions. For instance, infection, there was those allergic reactions, as well as transfusion-associated circulatory overload. And as a result, there are this mix of benefits and risks that need to be balanced and juggled, and there are no clear current clinical practice guidelines regarding whether or not we should be giving transfusions or when we should be giving them. And this is because most of the evidence, the systematic review evidence, is based on observational data. And those observational systematic reviews have given very mixed results, some of them leaning towards a restrictive strategy that I'll describe later. But we know that the gold standard of evidence is randomized controlled trials, and while some of these systematic reviews did include one or two randomized controlled trials, they didn't search for those specifically, and we decided to look just at RCTs to see if we could find anything different. So our research question could be broken down into the following: the population being adult patients with myocardial infarction and needing blood or having anemia. And then the interventions we wanted to compare was a liberal or a restrictive transfusion strategy. So liberal being we're giving blood at an earlier stage when their hemoglobin by volume is higher, and a restrictive being when it's a little lower. And the outcomes we wanted to look at were all-cause mortality, the recurrence of myocardial infarction, heart attacks, and stroke. And then the time frame to look at these outcomes was short-term, that being while the patients were in the hospital or within 30 days since randomization to one of those arms. And so the methods, just briefly, we followed the PRISMA guidelines for systematic reviews. That being, we did a database search, and then we screened the results from that search, looked at the certainty of evidence by the GRADE framework, the acronym is down below there, and then we did our statistical analysis. And so to summarize those first two steps of a database search and screening, we got just under 8,000 results, and we screened down to 3 suitable randomized controlled trials. And so in terms of findings, yes, those 3 randomized controlled trials had a total participant population of 821, which is really small. I'm sure you guys know that. And in all 3 of those trials, the transfusion thresholds they used was 8 grams per deciliter hemoglobin for the restrictive strategy and 10 for the liberal. And in all 4 of those outcomes that we looked at, there was no significant difference in terms of favoring one over the other. So this forest plot below is just the one for all-cause mortality. You see those 3 studies. The sample breakdown for each of those studies is 666 for the largest, and then 110, and then 45. So really 1 big study and then 2 proof of concept pilot trials. So with this limited evidence, we can tentatively conclude that opting to provide a blood transfusion earlier or sooner for this patient population might not be the best idea, and there could be more value in holding back and waiting, not only in terms of outcomes for that patient, but also in terms of saving blood. And so in terms of discussion, the sort of primary limitation, again, is that we have this limited number of studies. We're not really powered to determine any type of statistical difference. As well as when we're looking at that grade certainty of evidence, we rated it as pretty low for all of those 4 outcomes. So they're either low or very low. And that just means that the statistical result that we found could actually be very different from the true effect. And I think this forest plot, again, same one from earlier, kind of demonstrates that how we see the point estimates, they're not grouped together well, they're not on the same side of that line of no difference, and the confidence intervals as well, they all cross that middle line. So we can't really make any strong conclusions from this data. And so in terms of next steps, our search did identify 2 ongoing studies, and we were able to use the short-term data from the one with 666 participants. But there's also a larger one that had a projected enrollment of 3,500, so that's really exciting to see when they do end up publishing the results, whenever that happens. And so here are the references, and thank you very much, and I welcome any questions.
Was that your finding as well?
We didn't really look at the anemia status, but definitely the participant average age is definitely over 65, I'd say. A lot of comorbidities associated with that. But across all 3 studies, they were all similar. It would be interesting if we had a younger adult population also needing blood transfusions in that situation, but there weren't any trials with that data.
Yeah, because I remember having a conversation with Jeff Carson about that study that he's published, and he said that they were transfusing patients who couldn't walk across their hospital room. So they were so anemic.
So I've got a question. Most people who have a myocardial infarction have a normal hemoglobin. So how are you finding these people with these catastrophically low hemoglobins? Are they bleeds, or where are they coming from?
So I'm just repeating the question because I didn't hear all of it. You're saying?
Well, most people with a myocardial infarction have a normal hemoglobin.
Yes.
So you're looking at a very unique subset, must be a teeny minority. Where are they coming from? Do they have major comorbid conditions?
Based on my understanding of the situation is that they are just going in, they're in the hospital for their heart attack and they need to have a surgery, for instance, and in that surgery they've lost a lot of blood or need a blood transfusion. And so
okay,
that's
fine. Thank you.
Do you know if the studies that you included were just looking at myocardial infection of type 1 or also type 2?
They did look at some different definitions in terms of the myocardial infarction. Most of the participants in these studies were either NSTEMIs or STEMIs. I hope that answers your question.
Yeah, but there is the NSTEMI type 1 and NSTEMI type 2, and that's 2 different populations.
I don't think they broke them down. I think the large study did break them down, but the 2 pilot trials did not, so we weren't able to.
Thanks.
Okay, thanks very much. That was really interesting.